part of when we're going through the nursing process and taking care of patients, we document while we're doing things. As we come into a problem, if we can independently deal with it, which as you'll learn throughout the next 2 years, there's lots of stuff that we can make decisions and follow algorithms and use our PRN orders and handle a lot of problems on our own. So we just document that as we go. So we document our assessments, we document our patient responses, we can quickly document as we're communicating with different providers. As we sign off medications that we give, we're documenting those interventions. So we do all of that as we're going, and then we also have to communicate or collaborate with others at times. So sometimes the problem will be beyond our scope, or it's to the point where other people need to be involved and included in what's going on. So that's just part of the process that we stop and notify whoever needs notified, and then also document it as we go. Okay, so it all goes together. So this scenario that you went through, so it's a busy medical surgical unit at a community hospital. You've got some characters here. So you've got Nurse Emily, who's a newly licensed RN. You've got Nurse Marcus, who's an LPN. So his scope is not as great as the RN, but he's seasoned. He's been there a long time. Okay, so he might be more of like a supervisory person to Emily in her mind, maybe because he's been there. Mr. Thomas is our patient. He's got CHF. So we said his heart isn't functioning like it should. It's one of those things that once you have it, you always have it. And you have periods of exacerbation mixed with periods of remission. So maybe his meds got off, or he was having too much salt, or whatever happened, and he had a flare up, so he's in the hospital. Okay, and then the provider is Dr. Patel. Okay, so when we say provider, that's often a doctor, but nowadays it could be a nurse practitioner as well. So the provider is whoever is writing the orders. So whoever is in charge of the care of that patient, whoever is writing the orders. So it could be a doctor, nurse practitioner, physician assistant, are all different types of providers. Okay, and then there's a charge nurse. So this night shift does have a charge nurse supervisor at night. Not all places do. That's good that this one does. So there's somebody to go to if there's questions during the night. Okay, so it's 11:30 p.m. Friday night. The nurse does her health assessment, and the patient states that he's having worsening shortness of breath, or she notes worsening shortness of breath, new crackles in the lungs. So we'll talk about that Tuesday when we do head-to-toe assessment. But that's when you put your stethoscope over the different lung fields, avoiding bone, right? We go back and forth, top to bottom, or whatever pattern we want to follow. We listen to everything. And we should hear air moving in, air moving out. It should be clear. If we hear crackles, there's fluid in those little alveoli that shouldn't be, which lines up with CHF because his heart isn't pumping the fluid through his system like it should, so it's backing up into his lungs, so you hear those crackles. Okay, so there's new crackles. So he had been here, he had had assessment done before, there were no crackles. Now there's crackles. That's not good. Increasing edema. Okay, so all these things that are classic with CHF, but it's worse. It's a change than what it had been before. Okay, so increasing lower extremity edema. That means that when you go and assess their lower extremity and you press on it, it will indent. There's swelling, there's fluid collected in there. Okay, and then the patient is anxious, feels like there's something wrong. Okay, that's always an ominous sign. Okay, and then Emily isn't sure whether she should notify the doctor immediately. That's one of those difficult things on night shift. It's much easier during the day when everybody's there, but sometimes at night, if you're not sure of yourself and sure of following that process, you might be afraid to call somebody, afraid to wake them up. Okay, so not sure if they should call that Dr. Patel, shares her findings with that LPN, who tells her it's probably nothing. Just chart it, let the morning shift deal with it. Okay. Emily remembers from orientation that prompt reporting is important, but hesitates because Marcus is more experienced. Okay. Later that night, Mr. Thomas's condition deteriorates, requiring emergency intervention. Okay, so probably his vitals get so abnormal that they have to do like a rapid response. Does everybody know what a rapid response is? Everybody? So it's like a step before a code. So you can't call code unless they stop breathing or that's a code, code blue, and everybody comes and they do CPR and all the things. Well, a rapid response was developed, maybe it's been 20 years ago now that we initiated rapid responses, and it's like a precursor to a code. So not sure exactly what's going on, but there's something going on and I need more people to come look at this patient. So you can call a rapid response, and it's a group of like an ICU nurse, the ED nurse, whatever pharmacist is in the building, respiratory will come, and then there's usually a provider on the rapid response team. And they'll all come to your unit. They have like a set, preset orders. So like if this is what I'm seeing in my patient, I can go ahead and get these labs drawn. I can go ahead and get these drugs. I can go ahead and order these tests. So it's like before we get to a code, an emergency situation. And then at the end of a rapid response, usually that ends with that patient being transported to the ICU from your med-surg unit, typically is what happens. Okay, so they had to do an emergency intervention, and then during the investigation, so whenever your patient goes bad, they're gonna look through the charts, look through the communication to see, how did this happen, how could this have been prevented. So it's revealed that documentation was incomplete. Okay, so we don't have all the details, but maybe all those vitals weren't documented, maybe the lung sounds weren't documented, because part of your shift, you have to complete those assessments and document them in the computer. Okay, so documentation was incomplete, so what's supposed to be done was not done, and then there was a failure to notify the physician. Okay, so like I talked a little bit before, as you're completing your vitals, as you're completing your assessment, most of your systems are smart enough that they'll tell you, hey, like this is a change, you need to like increase your monitoring frequency, you need to let the charge nurse know. So somewhere along the way, the nurse should have been triggered, but they didn't follow up on it. Okay, so the situation raises questions about scope of practice, so knowing what you're responsible to do and carrying it out, professional standards go along with that, and then legal responsibilities, so consequences for not following your scope and doing what we're supposed to do. Okay, so you're supposed to split up and go through and kind of act out the scenario, and then there's some questions. Okay, so our first questions here are on scope of practice. So defining those duties that a nurse is considered competent to carry out and authorized to perform. What actions are within Emily's scope of practice? What task was she authorized and competent to carry out in this situation? Okay, and yours should look a lot like this. Okay, so she's an RN, so it's within her scope to complete an assessment. Okay, so it's within her scope to perform that head-to-toe assessment so that they can collect the data. It's within her scope to recognize changes in your patient's condition. Okay, so as a licensed nurse, it's part of my license, it says that I can collect data and I can recognize changes in their condition. It's also part of our scope and responsibility to notify the provider and then to document the findings clearly. Okay, so just repeating all of those things that we already said, that's just within our scope of practice. So not within our scope is deferring responsibility to the next shift while a patient's condition is deteriorating.
Can you post this to Brightspace?
Yeah.
Okay.
Thank you.
Okay, so remember the first few points of our scope of practice are the nursing process, right? It was assessment, diagnosis, plan, implementation, evaluation. Okay, so it's just our responsibility to follow those steps. Okay, standards of professional performance then. Okay, it said define competent behavior of all RNs and LPNs where care is provided in an ethical manner with respect for cultural diversity. Did Emily meet professional standards, communication, documentation, ethical care? What could have been done differently to meet those standards? Okay, so again, this is gonna get pretty repetitive, but she should have communicated the changes immediately to the provider. Okay, they probably would have just ordered an extra dose of our favorite drug, Lasix. They probably would have ordered an extra shot of IV Lasix, give them that, continue to monitor, probably would have been okay. Okay, documenting accurately and in a timely manner, okay, so everybody can see what's going on with that patient. Advocating for the patient's safety, okay, so they made a choice. They knew that if they waited, that patient would have bad outcomes, but they decided that the patient's safety was not important enough. They'll just wait until patient. Okay, and then Marcus discouraged a timely action which violates standards of collaboration and accountability. And then it said the Nurse Practice Act. So for us, we would go to the Ohio Board of Nursing to see all of our laws and regulations. What laws or regulations apply? Could this be considered a breach of nursing practice, and what are the potential consequences? Okay, so she could have violated the Nurse Practice Act by not notifying the physician. In many states, failure to report that significant change can be seen as negligence or malpractice. Okay, so negligence is not doing something that you're supposed to do. Malpractice is when injury results to the patient as a result of your negligence. Okay, and then some consequences for Emily could be investigation by the Ohio Board of Nursing or whatever state Emily's in, disciplinary action like reprimand or a temporary suspension or even revoking the license. And then if harm occurred to the patient, then even more specific personal legal action could be brought against Emily. All right, the next part, you were supposed to try to write a little SOAP note, so how you would organize that information and document what data you collected and then what you did about it. Okay, so SOAP stands for subjective, objective assessment, means like my assessment, like what I think is going on. Okay, and then plan. Okay, so we always start with the date and the time. Subjective, patient reports increased shortness of breath, states I feel like something is wrong. Objective, respiratory rate of 28, O2 sat 89% on 2 liters. Audible crackles in bilateral lower lobes. Okay, so when we listen on both sides, in the lower part, we can hear those crackles. And then anxious affect, which means their mood is anxious, so they're maybe fidgety, uncertain. Okay, so those are all the things we observe. Assessment, it's signs of fluid overload and potential worsening of CHF. Okay, so eventually, with knowing your patient's history and then collecting assessment data, you'll be able to identify, this is what I think is going on, this is the problem. Okay, and then plan, I notified the doctor at this time, I'm awaiting further orders. I placed the patient in high Fowlers. Okay, Fowlers is just sitting up, sitting on your back, just sitting up. Oxygen increased to 3 liters per standing order. Okay, so remember I said lots of oxygenation orders come with parameters. So it just usually will say increase to maintain their O2 sat above 95% or whatever it might be. So here's just a summary of what happened. Okay, if the communication is good and that doctor responds right away, you would include whatever orders. Okay, but at this point, they're not waiting. You don't want to wait till the doctor responds, because what if the doctor never responds and then it looks like you never did anything or reached out or documented? Okay, so that's an example of our SOAP note. Again, you could just document vitals and assessment findings in a flow sheet format, which is what EPIC is, and then just attach a little note to it. So there's different ways of doing our documentation. All right, and then reflection at the end, what would you have done differently? So all of you were saying you would have immediately notified that there's a change in the patient's condition because there's something going on, the patient needs more than just we can do at this point. That physician needs to be notified. Documenting, so I mentioned how the documentation was incomplete, so making sure everything is in there. Advocating for that patient even if a peer disagrees. How do personal values impact ethical decision making? So your personal integrity could affect whether or not you speak up, even against peer pressure. ethical principles, so we talked about these back in week 1. They're part of the PowerPoint today, so these again will be on exam 2 again. So beneficence, doing good, should be a motivating factor, not if I'm gonna bother the physician or something like that. And non-maleficence means doing no harm, so we know those assessment findings mean that that patient is not in comfort, they're in discomfort, and there could be potential consequences. So we don't want to do any harm. Okay, and then those potential consequences of the breaches in practice of not following up and not documenting everything, patient harm or deterioration, legal and professional disciplinary actions, and then loss of trust within the care team. All right, and I'll post that for you guys. Alright, so going through, there's lots of concepts that are covered in documentation. Okay, so the easy name of this lecture is just documentation. But everything that's covered, so we're talking about communication again, because documentation is our electronic communication. It's a record of everything that we've been doing for our patients and who we've been communicating with. Okay, ethical and legal practice is part of this, because it guides our actions with our patients and the steps we take. And then also because of confidentiality and documentation, those can be called into court, all of those records. Okay, so with documentation, we have to follow the ethical and legal standards. Okay, we'll get in trouble if we don't. Okay, so we have to document a certain way. We have to document continuously during our shift. Okay, just forgetting to document something is not okay. That's not a thing that we can do. Okay, so at first, when we're first getting started out, we have little notes to ourselves. You know, make sure you don't forget to chart this and that and the other. Okay, so it's a lot at first. But then once you're in a position for a while, you get used to the flow and you know what you're supposed to document. So it really just becomes part of your everyday thing. Evidence-based practice is just the reasons for why we do what we do. So for using the nursing process, and then using all of our electronic resources in our care for our patients. So using our electronic documentation, using those resources to collaborate with the providers, all of that is evidence-based practice. And then HIT is health information technology. So that's just being able to use electronic charting systems. Okay, and then professionalism is just guiding our behavior to those standards of practice or scope of practice, all falls under professionalism. Okay, so communication we've had before. This time we're specifically talking about exchange of information in the form of documentation. Okay, again, our documentation has to be legally compliant, and it has to be confidential. Okay, so that's the most important thing, is confidentiality. Okay, so we have access to all of those records, but it's only so that we can safely take care of the patient. Okay, and we only look up records on a patient that we're taking care of. A summary then of evidence-based practice. We use it for everything. Okay, it's just using the research, using the science, using the technology to guide our decision making. Okay, and then HIT are the digital, the computers, and all of that we use. Okay, it talks about how a lot of our systems support better decision making and reduce errors. So those ones that we put in the data and it tells us like, hey, this is not right. Increase your frequency of monitoring, let somebody know. Okay, and it facilitates communication. So when I first started, we'd have a HUC, health unit coordinator out at the desk, and we would let her know who we need. She would page that doctor, and then we would wait for them to call the unit phone, and then we'd have to go to the phone, and then we would talk to the doctor. Okay, now there's all kinds Most places have a Vocera. You guys all know what Vocera is? It's like a tiny little cell phone that hangs around your neck. It does intercom capabilities. You can have it call nurses that you're working with, call the secretary, call different departments, call providers, and they're hands-free. You can have like a little earphone thing if you don't want to use the speakerphone. It's also got a locating device, so it lets people know where you are. It lights up rooms as you go in them, depending on the facility that you work. Okay, so you might see Vocera, and then also just built into on the computer in Epic as they're documenting, they have chatting with the providers as well, so they can send a chat. They can include multiple people in the chat, social work and the provider and dietary, whoever all needs involved, they can just send those chats, and then that documentation is saved, so you can see that you've reached out to a provider. Okay, so it's much easier now. There's no excuse for not communicating and collaborating with whoever you need to, because it's so easy now. Okay, and then professionalism. So the main point of it is confidentiality. So we have access to so much personal information, but that's private. We cannot share that information. We have to protect access to the computer. So once you get into the hospital, you'll have your own login. You'll be able to log into the computer and look up patient info and chart things. You would never share that password, and then it's important to always log off and close up your computer before you would walk away from it. So nobody can look over your shoulder and see that patient information. All right, some critical thinking questions. During your shift, you notice that a nurse consistently copies and pastes old assessment notes into the EHR, electronic health record, without updating them based on the current patient status. Okay, so like we said, in the hospital, every shift, at the beginning of the shift, you fill out a head-to-toe assessment. And anybody who goes to that vital signs or head-to-toe assessment flow sheet can see that. You can see their whole head-to-toe assessment. They've been here for 5 days and get assessments, every 6 hours. You can just scroll back and you can see all of those head-to-toe assessments documented. Okay, so this is saying there's a nurse that goes in and instead of going through and filling out a head-to-toe assessment on their patient, they just copy and paste, copy over. Okay, so whatever the previous assessment data is carried over. Okay, meanwhile, so there's that going on, and then meanwhile, another nurse openly discusses patient information at the nurse's station where visitors can overhear. Okay, so we've talked about some of this a little bit, but what are the ethical and legal concerns in both of these scenarios? How do these actions affect patient safety and the integrity of electronic health records? As a student nurse, how would you respond professionally to these situations? What role does evidence-based practice play in documentation standards and protecting patient privacy? Okay, so maybe just take a couple minutes, talk to your partners about this scenario and see what you think.
Well, copy and paste them, could be copy and pasting all patient information.
Well, then she's not actually doing head-to-toe assessment, so she's learning that completing head-to-toe assessment could be
And also, confidentiality is not even existing at this location. Because there's that new female, whatever, or what's it called? ATM or something. I think that procedure needs to know that information.
Yeah, if the one is taking care of her next.
All right, anybody want to share any ideas they're having on this? Jasmine?
To the first one, definitely breaking HIPAA and negligence and potentially malpractice depending on what happens if they're just copying and pasting. They might miss something.
Yep, and so whether that patient stays or goes, right, gets discharged home, or, all the care that they're getting is based on what their assessment shows. Are they healthy, are they unhealthy, are they getting better, are they getting worse? So if it's not accurate, then that patient's not getting the care that they're supposed other thoughts? All right. We'll keep moving. The NCLEX categories then for documentation, so safe and effective care environment, obviously we have to document what's going on so other people can see and we can tell if the patient's getting better or getting worse. In addition to NCLEX categories, there's integrated processes, so these are themes that are woven throughout the exam. So like the nursing process is one of them, and so documentation is just part of using the nursing process. Talked about all that. Okay. Management of care, confidentiality falls under that. So again, we're in charge of those patients. We have access to all of those records, and we're discussing the patient information with everybody, but it has to be kept confidential and private. Okay, another integrated process woven throughout all of NCLEX is caring and communication. Okay, so requires demonstrating respect for the client's privacy and using discretion in all forms of communication. So verbal at the nurse's station, written if we have to do any of that, and then the electronic as well. Okay, safety and infection control just includes identifying and reporting those unsafe practices or violations, like copying over any documentation. Management of care, under that would be advocacy, reporting the unethical behavior. Again, if we're just falsifying documents, they're not getting quality care. Another integrated process is communication and ethics. So we have to be able to communicate concerns clearly and professionally, again, including reporting any violations that we see. All right, documentation. Okay, so health records or electronic health records offer numerous advantages. Before, we just had paper copies of everything, so we had to physically transfer or transport or send records from facility to facility. Now it's just electronic records. If you're in like the same family facility, like if you're in an Ohio Health Hospital, and then you go to an outpatient office visit, and that provider is in Ohio Health, they can see everything on their computer. They don't have to transfer anything. So everything is easily accessible. A medical history is lots of background info, so they don't have to go and start from the beginning and get all of that information again. Okay, before we had to handwrite everything, which is crazy, so there were lots of errors because of illegible documentation and mistakes. So those have been cut back a lot. And then there's more reliable coding and billing, which is on the back end. For you guys, you won't really think about that as much, but because everything is electronic now, that is a lot more smooth. All right, this is just a picture from your reading. So this is a computer on wheels. We don't see a ton of those. Usually, like they're in the patient room, along the hall, and then banked at the nurse's station. But some places you might see the computer on wheels, and they'll take it everywhere they go as they're caring for the patient. And it's just an example of how good those systems are, because they were about to go in and mess with this patient, but their lab results just notify. They just dinged, and they're on heparin, a blood thinner for their cardiac issues. And so it just notified them, oh, this lab value is up, so now I can adjust their blood thinner, their medication that they're getting. Okay, so it just goes to show how it streamlines everything. And the system is so nice, like when we're in the hospital, if we sit down and we look at your patient and we look at their list of meds and we say, you know, here's 5 meds we're gonna pull, we go to the med room, we pull those meds, we go into the patient's room. There's been times that in between that time, the orders have changed. And so then we'll scan that patient and start scanning those drugs. So it'll say this drug has been discontinued. So whereas before, that would have been missed because a provider would have had to write it down, then somebody would have had to go find it and then transcribe it and all of that. So now it's all like instantaneous.
Would you have to destroy the medication at that point, or would you take it
It
back?
depends. If it is open opened or not, because everything comes in individually sealed. They're all individually sealed pills, and opening them is the very last step. So we do multiple checks with it before we would ever open it. So hopefully during that scan, it would say, no, we don't need it. We haven't opened it, so we should be able to return it. Depending on the type of drug, you can return it. All right, here's the types of documentation. So you guys just practiced a SOAP note. So SOAP and PI and DAR would be either like handwritten or like typing out in a progress note. Okay, whereas CBE is charting by exception. That's using flow sheets. So as we learn about head to toe assessment next week, you'll see what charting by exception is. Okay, so SOAP is subjective, objective assessment and plan. So we just went through that. PI is problem intervention evaluation. So different way of saying the same thing. DAR is data action response. Okay, so just different ways of saying what's going on, what did I do about it, and then now what's the follow-up. Okay, so these are just different formats for if you have to sit down and summarize. I just had a patient, something happened with them. I collected data, I did an intervention, I let somebody know. We'd sit down and write a note in this format. Okay, documentation has to be factual. FACT stands for factual, accurate, complete, and timely. So not our opinion or not like it seems like this, but just subjective information directly from the patient and then objective information from us. Okay, the most important thing is documenting while we go. Okay, common medical abbreviations, that's your full study guide for today's content, is all those abbreviations that were in your reading. So go through and fill those out, make sure you're aware of those. Use those in documentation. There's a do not use list, which we won't really think about right now. That's just for like entering in the computer. If you're taking your own notes on your patient, you can write whatever you want. This would just be like if you're putting orders in, there's a list of things. And those things are on that list because they can be confused for something else, that they're too similar to something else. And then we talked about a little bit about receiving and transcribing prescriptions or orders. And I told you that we should never do that because that's not our job. They order the things, they're at the computer, they can put the order in. Why would I put the order in? You can put the order in. But some nurses think it's cool. They're like, I learned how to put the orders in, so I'm gonna do it. That's cool. Are they gonna come do your assessment, pass your meds, and do, no, they're not. So let them put their orders in. Okay, but if we do put the orders in, then we would have to be aware of these abbreviations that we're not supposed to use. I had mentioned how if our provider gives us an order, they give us the order, we have to put it in, we have to read it back to them, and then get a final, like, yes, that's what I want. Okay, so there's a whole big process. And then even after, once we've gone through that process and put it in, they still have to come back and look at it and sign off on it. So I'm just a big advocate for not putting in orders for providers. Okay, we'll just go a couple more slides here and then we'll finish this on Tuesday. So HIPAA, you guys should all know what HIPAA is. You've probably heard it a lot if you work at a place and then throughout all your schooling. It stands for Health Insurance Portability and Accountability Act. So health insurance portability means that it is portable, like you can access it from anywhere, but because it's so easily accessible, we still have to be accountable for protecting it. Okay, it all started back in the late 90s when we were looking to start the electronic health records and get everything electronic so that we could take better care of patients more efficiently, more comprehensive, but in doing that, we had to have some type of plan to protect that information. Okay, so just a background of the different laws where HIPAA came from, and it's just all about confidentiality and maintaining privacy of their records. All right, we'll stop here, and then we'll finish this on Tuesday, and then we'll have different activities and stuff to go through the information. Do you guys have any questions or anything for me at this point? Doing okay? Figuring things out? name tags